Welcome to the deep dive. Today, we are grabbing a stack of revision notes and doing a deep dive into a condition that is, well, incredibly common, something many of you will definitely encounter.
That's right. We're going to unpack everything you need to know about vasovagal syncope using the material you've provided. Think of this as your focused, high-yield guide, really pulling out the crucial details from the notes for revision.
Our mission is clear. Section by section, through this material, distill the key info, add some context, maybe some hooks to help it stick, and make sure you feel prepared, confident about this topic. Let's unpack this. So, right at the top, the definition. What exactly is vasovagal syncope? It sounds complex, but the notes seem to lay it out quite simply.
Yeah, the material calls it neurocardiogenic syncope as well, but essentially it's fainting. Frequent, maybe even the most common cause of fainting, that temporary loss of consciousness.
Okay, fainting. And how does this specific kind happen? What's the actual mechanism?
Well, the core mechanism, as the notes highlight, it's a temporary dip in both heart rate and blood pressure at the same time.
Both. Heart rate and blood pressure.
Yeah, both drop. And this combination, well, it just means less blood reaches the brain for a moment.
Ah, right. Less blood to the brain equals, well, the temporary lights out moment.
Exactly. It's triggered by a reflex involving the vagus nerve. When this reflex gets sort of overstimulated, it causes two things at once.
Okay.
The heart rate slows right down, that's bradycardia, and the blood vessels in the periphery, they widen. That's vasodilation.
So slow heart, wide pipes.
Precisely. Those two things working together dramatically reduce blood flow upwards to the brain. And that's why it's categorized under neurally mediated syncope, because of this nerve reflex.
So the name itself, vasovagal, it actually tells you quite a bit about how it happens, doesn't it?
It really does. That's a great memory hook right there. Vaso relates to the vessels, the vasodilation. Vagal points straight to the vagus nerve slowing the heart, the bradycardia. The name helps you remember the mechanism.
Okay, yeah, that makes sense. Now, what actually sets off this exaggerated reflex? What triggers a vasovagal episode? The notes list a few common culprits.
Right. The material points to several factors. Things like significant emotional stress or anxiety, prolonged standing, or even just sudden changes in posture.
Like standing up too fast or being stuck in a hot queue for ages.
Exactly. Painful or unpleasant stimuli are also mentioned. Think getting a blood test.
Or a vaccination.
Yeah, or seeing something you find really distressing. And finally, dehydration or heat exposure are listed too. But those classic scenarios where people feel faint, they really line up with these triggers from the notes.
So standing too long, getting a jab, seeing something squeamish covers a lot of ground. Who is more likely to experience this kind of reaction? Or some people just, predisposed?
The notes do identify specific risk factors. A family history is noted, which suggests there might be some genetic predisposition involved.
Oh.
And age is highlighted. It seems to be more common in younger individuals.
Interesting. So it actually tends to happen less often as you get older.
Yes, that's what the material seems to indicate.
Yeah.
Also, pre-existing medical conditions. Things like autonomic nervous system dysfunction, maybe some types of heart disease or epilepsy, are listed as potentially increasing susceptibility.
Right. Now, let's dive a bit deeper into the pathophysiology. The notes mention the full mechanism isn't completely understood, but they give us the key steps. And this is where it gets really interesting.
Yeah, what's fascinating here, pulling from the notes, is that it involves this sort of exaggerated response, an inappropriate response from the autonomic nervous system. The part that handles things automatically, like heart rate, blood pressure.
The involuntary stuff.
Exactly. The trigger stimulus, whatever it is, somehow activates that vagus nerve we mentioned earlier.
The vagus nerve, that's part of the system that generally slows things down, right? The rest and digest nerve.
That's the one. It has a big influence on heart rate and blood pressure. And when it gets that really strong signal in a vasovagal episode, it leads to that sudden, quite pronounced drop in heart rate, the bradycardia, and that significant widening of blood vessels, the vasodilation, especially in the legs.
And because those vessels are wide open, blood kind of pools down there away from the brain, leading to that temporary lack of flow and the faint. So it's like a normal body reflex just goes into overdrive.
That's a really good way to think about it. An overreaction of a normal reflex. Maybe for a memory aid on the pathophysiology, think of the vagus nerve like an emergency brake for your circulation.
Okay.
In vasovagal syncope, certain triggers just slam that brake lever down too hard. slows the heart, widens the pipes all at once, and the brain gets starved of blood for a moment.
Got it. Emergency brake slammed on too hard. Makes sense.
Okay.
Okay, so we've got the mechanism, but obviously if someone faints, it's not always vasovagal syncope. The notes are very clear about needing to consider other possibilities. This is the crucial bit on differential diagnoses.
Absolutely vital point. In any clinical situation, you have to ask, what else could this be? The material lists conditions that can look similar or definitely need ruling out. Things like cardiac arrhythmias.
Problems with the heart rhythm itself.
Exactly. Also, orthostatic hypotension, that's the blood pressure drop specifically when you stand up. Seizures, obviously, which are about brain electrical activity.
Yeah.
And then just other general cardiac or neurological conditions.
That's quite a range. Heart, blood pressure regulation, brain. How do the notes guide us in telling Vasovagal apart from these maybe more serious causes, especially using the patient's story, the history?
The notes really hammer home that the history is paramount here. They specifically say the history should not suggest things typical of seizures, like incontinence during the faint or biting the tongue.
Right, those point away from vasovagal.
They do. They point more towards epilepsy. Similarly, the history shouldn't involve exertional syncope fainting during exercise or a cardiac prodrome,
What's a cardiac prodrome?
like chest pain or really noticeable palpitations happening just before the faint. Those would be big red flags for a cardiac cause.
So the details around what happened just before, during, and after the faint are like the key detective clues here.
Precisely. The notes also add that a family history of sudden cardiac death is a really crucial detail. That would definitely warrant more investigation to rule out inherited heart conditions like certain arrhythmias or cardiomyopathies. Again, pointing back to those cardiac differentials.
That family history point is critical, yeah. Okay, thinking about how this might pop up in a test. Maybe an MSRA question described someone fainting after standing for ages, but they had no jerking movements, didn't bite their tongue. Based purely on these notes, that lack of seizure features helps steer you away from which differential.
Based on the notes we're looking at, the absence of incontinence or tongue biting strongly points away from epileptic seizures as the likely cause.
Okay, really helpful application. Moving on then. How common is this condition generally? The notes give some UK-specific numbers.
Yeah, the material estimates the prevalence somewhere between 1% and 3% in the general population in the UK.
1 to 3%. That's actually quite significant, which fits with it being called the most common cause of fainting.
Absolutely. And just like we discussed with the risk factors, the notes confirm it is indeed more common in younger people. It tends to become less frequent with age.
Okay. What does it actually look and feel like for someone having an episode? The clinical features, the signs, and symptoms.
The notes list several common signs and symptoms that often happen just before the person loses consciousness. This is called the prodrome.
The warning signs.
Exactly. Things like feeling lightheaded or dizzy, skin going pale, breaking out in a sweat, maybe feeling nauseous, blurred vision or tunnel vision sometimes.
Those classic feelings that you're about to faint.
That's the prodromal stage, yes. Then comes the brief loss of consciousness itself. That's typically followed by spontaneous, usually quite quick recovery once the person is lying down, or blood flow to the brain gets restored. And the notes really emphasize that the diagnosis relies primarily on recognizing this characteristic clinical history and these typical features, especially when you can link them to those specific triggers we talked about earlier.
So the patient's story is really the main diagnostic tool here. But if the history is so central, what investigations do the notes say are typically done? And which tests help rule out those other possibilities, the differentials?
You're right. History is primary, but investigations are definitely standard practice. A detailed medical history and a physical examination are fundamental, obviously. That's your baseline.
Right.
An electrocardiogram and ECG is listed as essential. You need to assess the heart's function and rhythm. This is crucial because it's a key way to help rule out those cardiac arrhythmias we mentioned, which can be serious causes of fainting.
So the ECG is mainly to check the heart isn't the primary issue.
Pretty much, yeah. It's a vital first screen for serious cardiac causes. Now, the notes also mention a specific specialized test, the tilt table test.
Yes, the tilt table test. Tell us about that.
So, the material describes this as a key diagnostic tool, especially for confirming neurally mediated syncope like vasovagal. It involves monitoring your blood pressure, heart rate, and symptoms while you're on a table that gets tilted upwards gradually.
To try and provoke an episode.
Exactly. It can actually reproduce the symptoms and that characteristic drop in blood pressure and heart rate in susceptible people. So it helps confirm the diagnosis and can differentiate it from other types of syncope like orthostatic hypotension.
Okay. What about other tests? The notes list quite a few possibilities.
Right, but the notes frame these as additional investigations. They're needed specifically to rule out other potential causes of syncope, especially if the history isn't perfectly typical for vasovagal, or if there are red flags suggesting something else.
So what kind of things?
Things like basic blood tests. A full blood count, FBC, could look for anemia, urea electrolytes, UNEs, check hydration, kidney function, things that might cause dizziness. An echocardiogram, an ultrasound of the heart, is listed if cardiac syncope is suspected, maybe if the ECG was abnormal or there are other signs.
Makes sense.
An EEG, recording brain activity, is mentioned if epilepsy is suspected from the history. And cranial imaging, like a CT or MRI scan of the head, might be considered if a neurological cause, like a structural brain issue, is suspected.
But are all these done routinely?
No, and the notes are quite clear on this. They state that often the basic blood tests and a normal ECG are sufficient unless the history or exam points strongly towards one of those other specific causes. The other tests are more targeted, further investigations for when they're really needed.
Okay, that clarifies the sort of stepwise approach. Rule out the big scary things first with basics, then get specific if the picture isn't clear. Maybe a memory tip here. Think of the initial workup history, exam, ECG, basic bloods as your wide net
Yeah, casting a wide net.
to catch common issues and screen for serious heart problems. Then the other tests, tilt table, echo, EEG, imaging, they're like specialized tools you only bring out if your net catches something suspicious, or if the story points you strongly in a different direction than simple vasovagal.
That's a great analogy. And applying that again, maybe for an MSRA question. Young patient, recurrent faints, classic prodrome like nausea, pallor. Their ECG is normal. Based only on these notes, what investigation is mentioned as being particularly helpful in confirming vasovagal syncope or differentiating it from other neurally mediated types?
Right, based on how the notes describe it, that sounds like a textbook case where the tilt table test would be the most specific next step mentioned for confirmation.
Exact.
Great. So we've defined it, figured out triggers, mechanism, risks, who gets it, what it looks like, how you differentiate it. Now, management. Once it's diagnosed, how is vasovagal syncope managed, according to these notes, particularly thinking UK context?
Okay, management. The notes really focus heavily on non-pharmacological stuff first line, especially for typical cases. Education and reassurance are key starting points. Patients need to understand what's going on, that it's generally benign, and crucially, what their specific triggers are.
And lifestyle changes look like a massive part of this in the note.
Huge part, absolutely. The material strongly emphasizes lifestyle modifications. Things like avoiding prolonged standing, especially in trigger environments like hot places, maintaining good hydration, drinking plenty of fluids, and using counter-pressure maneuvers.
Counter-pressure maneuvers, what exactly are those?
So the notes describe these as techniques the person can do themselves when they feel those prodromal symptoms starting the lightheadedness, the nausea.
Before they actually faint.
Hopefully, yes. Examples given are things like crossing your legs tightly while standing or clenching the muscles in your arms and fists really hard. These actions can help push blood back up towards the brain and potentially stop the faint from happening.
So empowering the patient with strategies they can actively use themselves.
Exactly. That's a major theme running through the management section of these notes. Practical self-management techniques first.
What about medication? Is that used often, according to the notes?
Pharmacological treatment is considered, the notes state, but usually it's reserved for people with more frequent or severe or particularly troublesome recurrent episodes where lifestyle changes alone just haven't been enough.
And what sorts of meds are listed?
The notes mention things like beta blockers, ephedrine, and SSRI's selective serotonin reuptake inhibitors. Fludrocortisone, which is a mineralocorticoid, is also mentioned, specifically to help increase blood volume and blood pressure if low pressure is a big issue.
Okay. And what about in really severe, rare cases?
For those rare, severe situations, especially if there's a really high risk of serious injury from falls during faints, the notes state that cardiac pacing, putting in a pacemaker, can be considered as an option. But it's definitely presented as something for specific difficult cases, not routine at all.
It really does seem like the notes prioritize that non-drug approach first and foremost, doesn't it?
They absolutely do. The material highlights that the vast majority of people have relatively infrequent episodes. They can manage their condition effectively just by focusing on identifying and avoiding their triggers, staying well hydrated, and using those counter-pressure maneuvers when needed. Simple, practical strategies are really the cornerstone for most people.
Maybe a memory tip for management. Think ABC of vasovagal care.
ABC. I like it. What's ABC?
Maybe avoid triggers, boost hydration, and counter maneuvers.
Avoid, boost, countermaneuvers.
Yeah, right.
ABC. Yeah, that works. Meds and pacing are further down the alphabet for when ABC isn't cutting it.
Exactly. Okay, so treatment is largely patient-led through understanding and behavior. What about the overall outlook, the prognosis section in the notes?
The notes are generally quite reassuring here. The prognosis is considered favorable. Most individuals experience infrequent episodes, and they're manageable with those lifestyle adjustments we've talked about. It's not typically seen as a progressive condition or something life-threatening in itself.
That's good to know. Are there any potential downsides or complications listed, even if the condition itself is benign?
Yes, absolutely. While the condition itself isn't dangerous, the main complication highlighted is the risk of physical injury from falls that can happen during a fainting episode.
Right, hitting your head, breaking something.
Exactly. Cuts, bruises, fractures, they're all possibilities. Recurrent or very severe episodes are also noted as potentially impacting a person's daily life, their quality of life, maybe limiting activities because they're afraid of fainting.
Understandable.
But the notes conclude by saying that early, accurate diagnosis, combined with good patient education and those management strategies, really helps to minimize the risk of these potential complications.
So pulling it all together from this deep dive into the notes, vasovagal syncope, incredibly common, usually triggered predictably, involves an exaggerated but generally harmless reflex, but importantly, carries that real risk of injury from falls.
It's a great example, isn't it? How a condition that isn't inherently dangerous in itself can still significantly impact someone's life if it's not properly understood and managed. And it really underscores why that thorough history and targeted investigation to rule out other things is so important.
Yeah. And what really stands out to me looking through these notes is just how much agency the patient has, how much power they have in managing their own condition once it's diagnosed correctly, mostly through recognizing triggers and using those fairly simple lifestyle changes and maneuvers.
Absolutely. And that does prompt a bigger question, perhaps something for you to consider as you revise. In conditions like this, where lifestyle modification is the absolute cornerstone of treatment, how can we as healthcare providers be most effective? How can we best empower patients to truly understand their own bodies, identify their specific triggers in the messy reality of everyday life, and then consistently apply these preventative strategies? It's definitely something to mull over.
That wraps up our deep dive into vasovagal syncope, hopefully running through the definition, the triggers, risks, the mechanism, the differentials, who gets it, what it looks like, diagnosis, management, prognosis, complications. Hopefully all that, plus the tips and scenarios, helps solidify this high-yield topic for your revision.
We've really tried to focus on extracting and explaining the crucial information directly from the source material you provided, aiming for the most relevant details efficiently presented.
Thanks for joining us for this deep dive. If you're preparing for the MSRA and looking for more resources based on distilling high-quality notes like these, do check out passthemsra.com.
And for free access to some really valuable revision materials, head over to freemsca.com.
Until next time, keep learning and keep diving deep.